Yeah. Yeah. Good afternoon, all. It's a great pleasure to invite all of you to the Oculoplasty cruise session. I think first time in the history of AIOS in Kochi, and as LOC member as well as the convener of the session, I'm very happy to invite once again. Hope everybody will enjoy this session. The boat will start moving at around 2:30. Then we'll finish 2 o'clock. 2:10. Yeah. Okay. Then we'll come back by around 3 o'clock. 3:30. Okay. Fine. So I invite Dr. Anida Sethi, then Dr. Usha Singh, madam, and Fairuz is not there. Will to chair the session. Yes. Where is the list? These are the people who are filing. Shall we start? Yeah.
Good afternoon, everyone, and welcome to this session on oculoplastic debates. Okay. So, welcome everyone once again to this oculoplastic debates. And the first debate is on globe reconstruction. Evisceration will be spoken by Dr. Aditi Pujari, and this will be versus enucleation by Dr. Rituja.
Good idea. We don't want music here, please. I should shout. So how many in a painful? Should I wait? Okay, so before we start the first debate, how many over here prefer evisceration for painful blind eye? Akshay, count.
1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13, 14, 15, 16, 17, 18, 19, 20.
That's okay. Just to get an idea. 20. Okay. And how many for enucleation? Oh, less, huh? Very interesting. Just interested. Yeah. Okay. So let's get started and let's see if we can change anybody's mind after the debate.
So, good afternoon, all. I guess we are just having this debate for. Okay, yes, academic reasons. The chairperson says that, yeah, that's what. So I'm just like, oh, okay. So I need to be serious about presenting. Yes, yes. Okay. Akshay is laughing. Fine. So, obviously, when we actually do any globe reconstruction by evisceration or an enucleation, what actually do we aim? When the patient has already lost her or his vision, good cosmesis can often be equated with the greater self esteem, and that is what we can actually aim for giving the patient. So that surely changes the life of the patient. So for globe reconstruction, our basic aim is to reconstruct the surface volume and give a acceptable cosmesis. So what are the objectives? Obviously, adequate comfort by relieving pain or removing the pathology, replace the volume adequately to give a good cosmetic result, and good functional and cosmetic improvement. We all know there are few absolute indications and contraindications for both the procedures. Obviously, enucleation, absolute indication will be intraocular malignancy. Obviously, there is a theoretical risk of sympathetic ophthalmia. But I guess the debate is actually for these cases, which are like listed below, where you can do either evisceration or enucleation. It's surgeon's choice. Where is painful blind eye, staphyloma, large staphyloma, thysis bulbi, cosmetic reasons, and trauma. So, what is the ideal end result from patient's perspective? Generally, we think of this good cosmesis matching. Maybe the eyelid contour might be slightly better than what we have achieved in this case. But from patient's perspective, motility has equal importance. So, it is not the primary gaze which is important. Motility, volume replacement, everything has equal importance in addition to the primary gaze. And they do want no lag ophthalmos. The eye should be closed properly. So, coming to this, what advantages do we have while we are doing evisceration over the enucleation? When we are doing evisceration, we are essentially removing the corneal button and intraocular contents. So, we are not handling the intraorbital contents, which is the fat and rest of the tissue. So, there is less disturbance to the muscles. They are actually at a natural place where they need to be. The fat is not disturbed, which actually results in less of the post operative long term fat atrophy, which occurs in cases where you are handling the intraorbital tissue, which in turn results in a better cosmetic result with less of inophthalmos and superior sulcus deformity in long term. Then, obviously, superior motility of the prosthesis because the muscles are in their physiological place, and incidence of extrusion or migration of the implant is obviously less likely because they have additional covering of the sclera and top of that tenons and then conjunctiva. And obviously psychologically also, you are not removing the eye, you are removing the contents of the eye. So patients, sometimes there are few patients who do feel psychological comfort when you are doing evisceration. That is what I have known from patients. This point I never noticed when I was like getting trained. So, what are the disadvantages of evisceration? Like, basically, in cases of intraocular malignancy, I'm very sure everybody, if they get such a case with leukocoria, child presenting with leukocoria when you're suspecting retinoblastoma, or any adult who is like you're suspecting something like uveal melanoma, you are not going to think about evisceration, obviously. And for the cases which you're not sure about the etiology, the imaging is surely going to be done, because like everybody is trained enough and they need to have all those DDs. So this surely is a pure contraindication for evisceration, but obviously that is never a debate issue. Obviously, rare chances of sympathetic ophthalmia, which we can just like cancel it by using the absolute alcohol to denature the uveal contents, and extremely small thysical globes. But we do have techniques like four petal technique, where we are going to make the petals and put adequate size implant, large implant, when you are actually reconstructing. So basically, when you are doing enucleation, you have the implant over the tenons and just one conjunctiva. Whereas when you are doing four petal technique or evisceration, you do have the implant over which most of the times two layers of the sclera, because you have done four petals, And then you have tenons. Over that, you will have conjunctiva. So it is better protected. So if you want some good result in disfigured blind eye, painful blind eye, thusical eye, I would say choose wisely and choose evisceration over enucleation. Thank you.
So would anyone in the audience like to ask any questions? We can take 1 or 2 questions per.
She a general ophthalmologist and orbital surgeon. She trained in orbital surgery.
Yeah.
Yes.
But she said it's not orbital surgery, it's anybody can do it.
The surgery is so simple and the technique is so precise and simple that even comprehensive ophthalmologists will be able to
So,
give a good outcome.
I'm going to differ with you there. The 4-petal technique is not something which a general ophthalmologist does. So that needs to be
Absolutely.
highlighted, because it is not that we've not had extrusion of implants and evisceration. I have also had. So we can have it.
Sure.
And sometimes equally difficult to treat. So it's the surgical technique, how well you do the technique, that is the important part. It is not just which technique. So yes, we must, when you say evisceration is the best, you have to qualify that it needs to be a well done. And in thusical eyes, it is very difficult to get even 1 petal. So thusical eyes mein to I'm not going to agree with you there. Traumatic cases also can be difficult.
Yeah,
So
it will, I think, even in thusical eye, it will depend on what volume, how much scarring is there. You
Yeah.
can still like try and fashion those flaps. And anyways, in after enucleation, you're going to put the implant in the posterior tenons space. So might as well just cover it with sclera.
yeah. So you're
And
kind of
preserve it.
doing an enucleation, but let's leave it at that. Thank you. Thanks,
thanks.
doctor.
So Usha doesn't even talk. They want the debate.
No, no.
So the initial question which was asked, that in a painful blind eye, would you do it? I think it's a little unfair to enucleation, but basically the thing is it's not really a debate. It's something that we need to agree that each one has its own indication. Now, Aditi, like a very angelic soul, has told you exactly what's great about evisceration. And I'll be just telling you very briefly in about 2-3 minutes. Now, the thing is, in a country like Jordan, which is quite similar to us, the issues that they've had with evisceration and enucleation are pretty much the same. So, like she mentioned, that you may have implant migration or exposure or whatever, the differences are not that much. They're almost pretty much the same. So, the entire debate rests purely on the indication. The technique is what matters. If you do a proper myoconjunctival technique, wherein you put the muscles back to their anatomical positions and put a fair sized implant right in the center, then you shouldn't have too many issues. The main advantage of enucleation is that you can have a proper histopathological examination where you suspect an intraocular malignancy. There are cases in which people have not picked up these intraocular malignancies clinically. They've gone ahead and done an evisceration, and that can be disastrous. So, when you suspect something like this, it's important. Is there reduction in implant motility? We'll see. In ophthalmos, you can combat that either by putting a fairly sized, good implant, 20-22 sized implant, putting in some fillers if you require it later for a superior sulcus deformity. So, is the implant motility a big issue? Not really. It's not as much as evisceration, but you do get a decent implant motility. I couldn't find any studies on this about the pain, but definitely clinically, I would have noticed that there is less inflammation and it is less painful to the patient post operatively. With respect to migration, doing a good surgical repositioning of the muscles makes sure that there is no migration and the migration rate is quite low. So a good outcome depends on adequate volume replacement. So you can do it whether you do evisceration, enucleation, whatever. You can get a good volume, making sure that the fornices are adequate, and most importantly, getting a good prosthesis inside. So the love is not lost between us, and I think Now the thing can be 50-50 that we do where it's required, either surgery. Thank you.
Okay, so yeah, that was very well put. And I think we can qualify the question, not generally all cases, but in maybe a traumatic case or a slightly mutilated eye, how many will do evisceration? I think we should level the playing field. Of course, the absolute indications for both are there, but if it is maybe slightly mutilated or a traumatic eye, then how many would prefer evisceration over enucleation? Is it still?
In some of these trauma cases, we still have more field to play around, in the sense like if there's sufficient amount of sclera, so evisceration is better in that way. Like in bullet injuries and all that, you can still fashion out the scleral petals and then do the suturing. So I feel in adult patients where it's a non-malignancy cases, evisceration is, I would go with it.
I have a question to House. Has anybody seen occurrence of sympathetic ophthalmitis after evisceration? Though it is mentioned in literature.
Sir has seen.
You have seen?
So now you know who's the oldest. It's a far less recognized condition as an entity. They manage uveitis, but they don't realize it's sympathetic ophthalmia a lot of times. And I think what is happening is we say, yeah, it can be managed easily. But if you're all treating migrant workers who are possibly going to go back to the villages, remote
got few
areas in the
announced.
future, not sure about what is the certainty of medical care they're going to get. I'd rather reduce the certainty, even though scientifically it's been shown that the risk is not that high. Absolutely right. We know it's not the uveal tissue at all. People talk about retinal-less antigen and all this stuff. The fact that you had a mutilating trauma with extravasation of all the intraocular contents to the ocular subconjunctive space already is predisposed to it. But I think for more reasons than one, not that I don't like Aditi. Possibly I like Ruchija a little bit more. For all the purposes, even if you tell a patient there's a very low risk, you can have a problem in the other eye. If you tell it in a proper way, most patients do not want to take that risk, especially if it's a 20-year-old occupational injury as opposed to a 75-year-old. Including myself.
Yeah. Thank you. Thank you, Dr. Ruthija and Dr. Aditi. Sorry. No, don't be so serious. There are few announcements. Now you can look into all the surroundings. On one side, is no. On one side is the White Bridge, and there's a church, but that has disappeared now. On the other side is the Marine Drive. Yeah. On the back side is a container terminal, like the freights come and go, all those things. And there is another floor on the top of this ship. If somebody wants to enjoy the first floor, then they can go and enjoy. Then you can come and attend the session also. Gold mine. Gold mine is around the next to some of the ladies. No, I don't know. Sorry. When you find it for us from Kerala, just let us know.
That's the name.
Yeah, coming. Soft drinks, biscuits, refreshments are coming. Gold biscuits.
That is below the Lulu Convention Center. Dubai people have made.
So, okay, next. Yeah.
We started with the most serious topic. What to do?
You can start with that.
Who's the next one?
Endoscopic DCR versus external DCR. Mukesh is going to speak on that. So again, let's take a poll. How many are doing endoscopic DCR?
No, that is not the question.
Why?
The question is.
No. You can't change the question.
How many are doing endo-DCR is not the question. The question is if you have nasolacrimal duct obstruction.
No, that is your
would
talk.
You want me
That
to
is
do
your
external
talk.
DCR or Javed Ali to do endoscopic DCR?
Okay, no,
That is the question.
okay, that is the question you will ask. I just want to know that how many are doing endoscopic DCR? Okay, so very few are anyway doing it. Okay, fair enough. And then, yes, at the end of listening to both of them, we will find out who wants to do what. Okay.
All right.
Actually, you're bullying her. The judges. Exactly right.
All right. So I know it's a little odd because yesterday Dr. Mukesh and I were sitting together in another session where I was talking about external DCR, and here we are sitting on opposing side talking about endoscopic DCR. This is general background. So what is the perfect DCR? What do we call a perfect DCR? It's one where most importantly the patient is at ease and not anxious during the surgery. So a surgery with adequate anesthesia, minimal bleeding, good ostium creation, because functionally creating the ostium is most important part that remains patent, with good mucosal apposition, with that is possible only with flaps, minimal scarring, which means less cautery, less intraoperative time. So if we do all of these right, we'll hit the perfect score of doing an external DCR. A DCR. And we have two ways of doing this. You can either do it endoscopically or externally. Now, external DCR, we keep telling is the gold standard, gold standard. But what is a gold standard? Who defines a gold standard? Just because it is technically easy doesn't mean it's the gold standard. The gold standard is a surgery which is safe, gives good outcomes anatomically and functionally. And what if I tell you if you can get the same results with an endoscopic DCR without the ugly scar? Because everything that glitters is not gold. So gold standard is out. And when we talk about endonasal DCR, we are talking about the most latest way of doing it, which is endoscopic endonasal DCR. And if required, you can use an electronic drill as well. And why I prefer an endoscopic DCR? Because none of your major structures like the angular vein, the angular vessels are touched. The medial canthal tendon, which I prefer to cut in an external DCR to reach the fundus of the sac, that is left intact. Essentially, the medial canthus and the lateral canthus, the hammock is left untouched. So later on, lid laxity doesn't develop. There's a clear visualization of where the pathology is and where you're creating your flaps. And you can do that. And even a beginner will find it easier. We're not dissecting orbicularis. We're not touching the medial canthal tendon. The blink phenomenon is left untouched. Concurrently, if you have any intranasal pathology, like a deviated nasal septum, a hypertrophic turbinate, all of those can also be addressed. By whom is different, whether it's an ENT surgeon that comes and assists you, or you go and do it with an ENT surgeon. That is not the debate here. The debate is which is a better technique in terms of outcomes. And this is to show you simplistically what exactly happens in an endoscopic DCR. So we are going here, we see the axilla of the middle turbinate where we initiate a mucosal flap with a sickle knife, raise the flap, and the bone that you see, that basically is the junction between the frontal process of the maxilla and the lacrimal bone, and that is where we normally would initiate the ostium. Do it with a periosteum elevator, and with your forward punches, you just need to go in, engage the bone, and punch just like you would in external DCR. That glistening pink patch you see, that's the lacrimal sac. Two punches and you're seeing the lacrimal sac. You're directly addressing the region where you need to make a flap. All you need to do is adequate clearance of the bone. With due course of time, when your hand-eye coordination develops, you will be able to go ahead with precise bone removal and excision and exploration of the area. With using a keratome, you can make a flap, and there you already put in a probe, so you can see how the sac is opened up like a textbook. All you need to do is oppose it to the mucosa, and there is mucosa to mucosa apposition. Put a little mitomycin C. If you want to intubate, you can do that. Come out and put a nasal pack. No suturing, no bleeding, and you're done in 20 minutes. Technically easy, even more simpler when you do it with adequate decongestion. So success rates, endonasal DCR is comparable. I'm not going to go through literature. Enough papers talk about both of them. Endoscopic versus external, even in primary, in pediatric and revision cases, both are equal. Especially in revision cases, because we know the most common causes of failure in external and endoscopic DCR is septal adhesions, small cicatricial scarring at the ostium, and all of these you're able to visualize with your endoscope directly and address the pathology causing the failed DCR in the first place. So here there is no need to go through the scar where you've already incised. You don't need to fight through all that mucky material in a revision DCR. You go straight up, visualize the ostium, understand what went wrong, and revise it in a revision case. So you can also do it in an acute dacryocystitis. I can, from an ophthalmologist perspective, there will be teething troubles. It's okay. So the cases where I will still prefer an external DCR is an elderly patient who cannot get GA, where there's a fistula, a traumatic or a secondary NLDO, or any other patient who prefers an external over endoscopic for reasons. Otherwise, an endo DCR is offered to every patient. The future is already here, so it's quicker, it's faster, it's scarless, especially in revision cases. So that is why I prefer an endoscopic DCR. The block is in the mind.
So that made it look really easy. What about the learning curve, Akshay?
So Saurabh has published this paper about his learning curve and outcomes of the first 50 endoscopic DCR surgeries done as a fellow in a tertiary care institute. And what his outcomes, what he published was that when you're at the 20th surgery is when you start seeing a radical decrease in your surgical time, and the success rate between the first 25 and the second 25 are significantly different. So I think you need to fight through those first 25 cases. When you get used to using two hands, you're getting used to looking at a screen and operating down, and you're getting used to using your left hand much more than what you would in regular surgery. So I think 25 surgeries, much like cataract surgery, is the number that you need to start feeling comfortable.
There are
What
more
anesthesia do
cataracts.
you prefer,
There are
Dr.
more
Akshay?
cataracts.
General anesthesia, ma'am.
Okay.
Locally, now of course I'm able to do them under local, but for a long time I still prefer general.
It's not very easy in local because you have a lot of these drill machines going in and putting 3-4 instruments, and patient is, I don't think it's a very good experience for the patient.
Younger patients, you're able to get away, but I agree, especially if you have a little more bleeding than anticipated, having to put a throat pack and suction and irrigate, the patient gets a lot of fluid in their throat.
Well, a long external DCR is also not comfortable. So now we'll hear the other side from Mukesh. This one is actually the other side.
All right. So after this fancy presentation by Akshay, well, I have got no financial disclosure, and also my talk confirms to the propriety. Unlike a healthy person sitting here in t-shirt, yesterday he was saying that he wants more and more persons to do endonasal DCR so that they can fail and come back to him so that he can earn money. So here, what we talk, we do.
Personal communications.
Yeah. No, it was based on his own presentations. Then I have got few acknowledgements to make. Some of the concepts here used here are taken from the Akshay Nayar's presentations yesterday. So if you are supposed to do a DCR, you want to choose a single procedure which can handle fibrosed or fistulous cases, which can handle associated common canalicular block if it is there, which has to be the most successful single procedure, and of course, which can address failed laser or endoscopic DCR. So you want to have a single procedure as external DCR. You do not want to go into the reverse order. First you do a failed endonasal DCR, and then you come up and do external DCR. So in DCR, we all create an anastomotic tract which gives us a drainage and which is the reason for success of DCR. So what is there in anastomotic tract? What we can produce? A double flap anastomotic tract obviously is the best, anteroposteriorly epithelialized tract. If you are making a single flap tract, again it is good. It is almost close to the best. Partial flap suturing, all right. But no flap suturing, it is uncertain. And it is the case in fibrosed, it is the case in endonasal or for that matter laser DCR. So now it is your personal choice whether you want an epithelialized anastomotic tract or a tract formed by a granulation tissue which is uncertain. So there are certain myths about external DCR as propagated by my fellow speaker. So it is not yet an outdated procedure. It does not bleed profusely. It does not take long time. We all do it in 15-20 minutes, maybe faster than what our fellow colleagues they do endonasal DCR. Cosmetic disfigurement is absolutely unusual. Those all scars are not at all disfiguring. In 1 to 2 months time, patient will not be able to appreciate that. Increased morbidity, maybe little bit more for initial 2-3 days, that's it. And patient demand, it is created by the doctors, not by the patient. If you tell patient that there are options of a scarless surgery which is better, then only patient may opt for it. But if you tell genuinely patient about the actual success rate of the procedure and the scar which is almost invisible after 1 month or so, patient will leave the choice of surgery to the surgeon. So it is your conviction which is important rather than the patient choosing a procedure. So incisions of external DCR we all know. So I'm here between all I don't know how to play it. I go here. So though I'm sitting here, just a second. Yeah. So we make incision. You can. It's not phosphor. You go to the MPL. You incise the periosteum. You can use knife or the cautery, whatever you wish. So this is the simple procedure which we all are doing from edges. We know that it is really a successful procedure. You suture, you make the flap, you inject lignocaine with adrenaline into the opening, initial opening, you enlarge the opening. And one other important part is that you can make opening as big as you want, unlike the endonasal DCR. And then obviously the suturing of flap. So this is the anterior flap. Sometimes flaps are so large that you need to resect them just to prevent them from bulging in, and then suture it, and you are done with the surgery. So I think with this I am done with the presentation. Thank you for your patience here.
Okay, yeah, that was very forcefully spoken. Just a question. So, would you say there is absolutely no indication for endonasal DCR? Are there any cases in which you would do it? Debate aside, but this is scientific.
Well, actually, nowadays, after seeing people doing endonasal, and one distinct advantage that you are keeping the functionality of lacrimal pump intact. You are not disturbing the orbicularis. So all those uncomplicated cases, clear-cut case where there is regurgitation of pressure, no recurrent history of acute dacryocystitis and all, I would like to go for endonasal.
That was kind of him. Yes, doctor. Yes. Suspicious for? So that's a good point. So a suspected malignancy should definitely be a contraindication for endonasal. I would say.
Clinically, three things that you almost always get in a sac malignancy is the mass protruding going beyond the MPL,
Yes.
hemolacria, and
No
firm mass
regurgitation.
rather than a cystic or a compressive mass. If these three things are able to identify pre-op clinically, endoscopy is already after the baby.
So I think suspected malignancy definitely. I mean,
His question is after you've done endoscopy,
now what will you
find
do?
a mass in the sac and you massivelize the sac. What do you do next? Is what he's asking.
Yeah, say open above and take it out. Right? You'll have to go back to an external and you'll have to excise it. And
Milan, what would you? You bump up your malpractice premium.
I
do
think
endoscopy.
there is a recent study of 205 patients with 101 group and the other 105, and they have found that their results are equivocal, and both the procedures are good, and you can do as per your requirement
he's
or the
asking
situation.
specifically.
No,
if-
I'm talking. I'm not
Ah,
answering his
acha.
question. I am. Another thing is there was one. Where would we prefer endo DCR? So especially, I would like to prefer endo DCR in those children who come with acute dacrocystitis, and they are the ones you just drain it from the endonasal route, and they respond rapidly and beautifully, and they get. You don't need to give a. The children especially benefit.
I mean, to answer your question, you're right. It's a very practical question. Clinical suspicion is there, then you're right, imaging and direct accordingly. We do occasionally see this, and typical tumors we see are inverted papillomas, which are nasty, benign tumors because we don't excise them completely first time around. They're going to be recurrent and recurrent, so on and so forth. So the principles there, if you identify a tumor, if you think it's a melanoma, for example, or papilloma, you want histopathological confirmation. You do not even have a consent for a complete dacrocystectomy on these patients. So you do your tumor removal, get your histopathology, stop the surgery, have an informed discussion with the patient and the family after the patient is away, because usually they're under GA. You can't go talk to the family halfway through and say, I'm going to do a medial maxillectomy. People think that you marsupialize a tumor to the nasal cavity. All medial maxillary tumors can be endoscopically resected nowadays. We hardly do external incisions anymore. So that's not a contraindication, but after the consent, you go back in within a week or two, go ahead, complete a more radical procedure. That's what we have done in our practice.
No, I've never had the fortune or misfortune of facing this situation, but we'll keep it in mind if it were ever to occur. So I think that was a really good discussion. And after tea, maybe we'll ask people, do they want to, if they had a NLD block, will they go to you or to Javed? Yeah. So now we'll go on to the next topic. Shilpa is going to talk about the anterior approach to ptosis surgery. Oh, yes. Okay. How many do posterior approach ptosis surgery? Okay, not too many. And mostly everyone does anterior approach? Okay. So you don't have to work too hard, but I see the other person does.
So I feel it's the easy one. You excise the skin orbicularis, and there lies the levator, just there for you to see. And in ptosis, as we all know, the aponeurosis has slipped back, and we just need to pull it ahead and suture it to the anterior part of the ptosis. And when we need to suture it to the anterior part of the ptosis, why do we go from the posterior side? And in cases with dermatochalasis, I would like to ask my worthy opponent, what does he do, the anterior or the posterior approach? So I think it is always useful to have the lid crease incision to incorporate blepharoplasty with ptosis, and especially in cases where we need to do fat removal also in blepharoplasty cases. Again, to create lid crease, in cases where we want to form the lid crease properly, we need to take the anterior approach, obviously. In cases of residual ptosis, if there is undercorrection, it is always good to go from the anterior side and see the levator properly, because we can dissect the horns, we can see the entire extent of the levator and correct all the abnormalities which are present. Like in this patient, there's excess skin, there's lash ptosis, and there is contour abnormality. And we need to correct all that along with ptosis, along with undercorrected and residual ptosis. So anterior approach matters again. Similarly, in this patient, there is a notch, as you can see in the left eye. And if we need to correct that notch, again, anterior approach helps. Patients in which there is desired intraocular surgery, post-operative, after ptosis surgery, it makes sense to do anterior levator resection. And again, in cases of severe ptosis, where we need to do supramaximal resection, as in this child, so again, levator resection from the anterior side matters, which can give good correction. So Everbook's approach, proper exposure to the levator mainly, and availability of adequate amount of levator muscle for resection after cutting the horns. And where would you go to learn levator resection, which is bloodless, scarless, and quick? Where would you go to learn that? Dr. Milind Naik's YouTube channel. Okay, so I don't know. We must be anterior and be ahead.
All right, that was very good. So my question to you is, that means you will do 100% skin approach? There are no
Ma'am,
indications for
so
posterior
I have
approach?
not learned posterior approach levator section. That's why I do not do it. I have learned only the anterior approach. Maybe if I learn it, maybe I'll find it better. I
So
don't
you
know.
need to watch his
Yes.
YouTube channel some
But
more.
he has not posted that.
That's your fellowship, is it? That's your fellowship.
Yeah.
Well, thank you. Okay, good afternoon, everyone. So, posterior approach surgery is done from behind the eyelid. And because it's behind the eyelid, you don't see it. And that's why there is no presentation today. Okay. And Shilpa is a good friend, so I'm actually going to support anterior approach. Anything that's done from the posterior approach in life is not good. For example, stabbing in the back. So similarly, posterior approach surgery is something which I don't prefer so much. It's very few cases where I do it. Just to clarify, posterior approach is actually of two broad categories. One is the MMCR, which is the Mueller muscle conjunctival resection, and the other is to approach the levator through the posterior incision. So these two are different concepts. The second one I have never done in my life because that comes from a European descent of training I never had. So I do not know how to compare that. MMCR definitely, despite the fact that I call it ocular circumcision, I still do it in some cases because there are patients who have mild ptosis, who have good levator function, and it's a good case in them if they are not keen about having a scar, just like endonasal surgery. But I do agree that skin crease is not under my control. Sometimes I do get undercorrection despite a good phenylephrine test, and vice versa. So these are extremely few cases whom I tell that this is your stage 1 surgery. MMCR is your stage 1. If stage 1 works, everything is good. We don't meet again. If it doesn't work, we meet for anterior approach. So that's my philosophy. Maybe 2 or 3 out of 100 is posterior approach. Most of them are MMCRs. And nowadays I do conjunctiva sparing MMCR. Thank you.
Okay. Okay, that is very interesting. Yes, Akshay would like to say something.
There's one set of even more mutilating posterior approach surgery, which is fascinella servant. So in an acquired ptosis, it's a dehisced levator, it's a thinned out levator, or in a traumatic ptosis, it's a detached levator. And here you want to go and address the tarsus and the conjunctiva, which physiologically doesn't make sense. So, and also the tarsus, the meibomian glands have a function. It's a thin tarsus in the upper eyelid. You don't want to, so fundamentally and in principle, a lot of oculoplastic surgeons like me don't prefer fascicular
So this
servant.
is not part of this
So
debate.
no, but I think posterior
MMCR,
approach. Okay,
MMCR
all right. It's still posterior approach. That's why I said it.
yeah.
Is very difficult to get a levator bite. So again,
Yeah.
so just to add, if you think removing Mueller's and conj is circumcision, when you remove Mueller, conj, and tarsus, I don't know what it is.
But those who do, even I don't do posterior approach elevator resection. Those who do it, the lid crease is really very nicely formed. And it is a good procedure. It's just that I think we are all so used to being trained on anterior that we just don't, why fix something that isn't broken? So we all prefer to do the anterior approach. But for mild ptosis, I think the MMCR is a really good procedure. It's much faster. And all said and done in LPS, sometimes it does behave very unpredictable. Say the acquired ptosis or the senile ptosis, it can sometimes be very unpredictable. So I think for the mild ptosis, MMCR is actually a really good way to go. Okay. Anybody else?
Yeah. Actually, I do posterior approach surgery also in maybe 15-20% of cases, levator resection. But one thing which is there in my all posterior approach surgeries, and for that matter sling surgery also, in more than 50% of cases I do symmetrizing resection of skin and muscle, because I feel there is some overhanging of skin and muscle after any surgery, be it frontal sling, be it posterior approach levator resection, and sometime in MMCR also, if you are doing it little bit too much, if you are resecting it too much.
Because that's a really nice part of the view.
Oh yeah, yeah, yeah.
And I think the sea is over there. This is better than spotting the elevator.
That's
Oh, that is so pretty. Marian, that's the sea over there, right? That side? That's the sea, no? Looks like, yeah. No, this is the backwater. That's the beautiful thing about Kochi is backwater and sea right next to each other. Gorgeous. And Marian, what is this long thing?
That is a traditional process, Mattanchedi.
Oh, mutton.
Mattanchedi. Mattanchedi was the
Palace.
old Kochi. No, it's old Kochi. Lots of industry, tradition, tradition houses, everything.
No, but it's so pretty.
Yeah.
Yeah, Milinda.
There's one more advantage of the anterior approach, which I feel when you're doing it under the microscope, it's easy to identify every layer, every structure, every millimeter, and it's easy to teach also to your residents. That's one advantage of. So,
Okay, so now we'll go to the next talk in which we are talking about navigation in orbital surgeries. And Dr. Usha Kim, will you, Gangadhar has asked if you can go first.
I think it would be nice if you go first.
Okay.
Good if you go first. Yeah, thank
Okay, I think she wants to only speak on what you speak. Yeah? All right, so you can go first, no problem. And how many are using navigation in orbital surgery? Anybody here other than Milind? Navigation in orbital surgery. How many are using?
They don't use it.
Hai na?
They have it and they don't use it. Chennai, Arvind has it, they don't use it. Yeah, sir.
Now you'll use, na? After they tell you how good it is, now you'll use. That's why you're here on the cruise, isn't it?
They're planning to send it off because I need a place to manage.
Thanks. Well, it's great to be back to the Indian meetings, and this is far more fun than the scientific deliberations we have, which is so formal out there. And we can have an honest discussion and still maintain our friends. So Usha, you'll still be my friend afterwards. Okay. First,
We've got some bouncers here to make
all right.
it doesn't come.
No, Akshay is always on my side. Anyway, how many of you own cars? How many of you have GPS in your cars? Almost the same number. Almost the same number.
Okay.
Which tells you that if you're going to drive a car, whether you're driving home, driving to work, or renting the car or going somewhere else, by default, if you have access to GPS technology and you can afford it, you're going to get it, correct? Anybody wants to say no?
Yes. I'm the one who's going to say no.
She's going to say no later on. I'll deal with Dr. Usha later on as well. Some disclaimers. Number one, I'm not as great a surgeon as Dr. Usha. Okay? So there are situations in the orbit where I go in. I'm not really sure where I am. Sometimes I'm digging deep inside the orbit and I tell my fellow, do you see the posterior ledge? They all say yes. How many of you are guilty of doing that without seeing it and you just say, that's the optic canal? Don't worry, Kasturi is not here. Yes or no?
No.
They always show you the posterior ledge. They always show you the optic canal. So we fellows are all guilty of just nodding our head when they say, believe me, I'm there, because you dare not say no to Dr. Usha or Kasturi. Milind, maybe yes. Okay. So there are parts in the orbit where we think where we are, we dissect, we reduce, we stick an implant inside, and the patient's doing well, you just say, I did it. But how many of you who do fractures routinely image your orbits post-operatively? Akshay, Prithija, Usha.
Sometimes.
When do you do it?
Post-op follow-up. I have to come and show off in the conference.
Only then, yeah? In other words, a lot of times we are sticking implants inside the orbits, and as the patient's doing fine, you really don't want to know where the implant is. You're scared it's not in the right place. You're scared it's not really covering the defect. So this is very similar to doing refraction after refractive cataract surgery. Does a cataract surgeon ever not refract a patient post-operatively? You always refract just to make sure you got your target refraction when you're off, overcorrected, undercorrected. And that's where all this is coming about. So let me show you some pictures and I'll call this to an end. If you can see this, for example, these are all pictures of patients who have had orbital surgery by accomplished orbital surgeons and craniomaxillofacial surgeons who always say, yeah, I saw the posterior ledge, who always say, I put the implant on the posterior ledge. And where is the implant? That's a posterior ledge in the orbit. That's the implant in the maxillary sinus. Likewise, when you're trying to really place it against the posterior ledge, you want to really get up to the posterior ledge. Okay? You all can see this, right? But you can see where it is. You're trying to get it on the posterior ledge. It's impinging against the inferior rectus, postoperative diplopia. So we all think we know where we are, but the truth is we really don't know where we are, especially the most posterior orbital or apical structures you're dealing with. Okay? Anyway, I have other pictures I'll show you. But the bottom line is that when you're deep inside the orbit, classic examples are full flow fractures. Sometimes there's no posterior ledge. The blowout fractures where there's a combined floor medial wall defects. Again, we don't know where the floor is, where the posterior ledge is, where the medial wall is, and you don't pre-bend these implants. We empirically bend implants. We stick them in. We put it on the floor, but not the medial wall, put it on the medial wall, not the floor. And we don't image these. These are the patients who end up having problems. So bottom line, my take-home message, and I'll rest my case, is if you own your own car, if you have a choice of having a GPS, you have your GPS. All of you use your Google Maps on your phone. That's what navigation technology is all about. When you're doing complex fractures, learn to use navigation for two reasons. Number one, you want to be sure where you are. And number two, when you're training residents and fellows, you want to really show them the right way of doing it. So if you're an inexperienced surgeon doing complex work, you start using good technology until you become a master at Usha's level. Then she can do whatever she wants. Thank you very much.
So, I mean, this is really interesting. So, do you feel that after using the navigational software, we won't get any results like that? Is that what you're saying?
So I have talked.
I just want to know.
Yeah, absolutely. So the success of surgery is multiple factors, not navigation alone. There are GPS guys who rented cars on GPS, went on an Australian holiday, followed the directions, so on and so forth, realized they were underwater because GPS did not show it was high tide when they were driving. So blindly following navigation technology is also not flawless. It's a combination of experience, combination of exposure, large enough incisions if you're a beginner, combination of visualizing with your naked eye, visualizing with the tip of your instruments, and the navigation technology. And when you put your implant in, go back and navigate again and right at the apex. If you have the luxury, do even intraoperative imaging of orbital fractures, which we do for complex and revision fractures. Is a combination of things which makes it a success. It's like you're cooking something, it's not the salt, it's not the pepper, it's not the chili. It's the right combination of everything which gives you a good meal.
So complex fractures are going to you. Where's Milind? Milind? Not here? Okay, over to Usha then.
Yeah, just to remind you what Ganga was telling. It is on, I think. Yeah. Can you hear me, Akshay? Yeah. So just to remind you, these are for beginners. You buy the navigation unit. Beginners, listen properly. Buy the navigation unit, learn it, learn your surgical procedure with the navigation unit. You're a beginners. Remember this point, okay? Number two, I just wanted to ask you all, how do you eat dosas? Hand, okay. Or the complex fork and spoon? Chopsticks. Okay, yeah. So we'll remember all these points as we go on. Huh? So this is what we start. Gold, okay, fine. Yeah, so this is all we need actually. We need to know our anatomy. We need to plan our surgery. So it's examine thoroughly, Dr. Ganga, investigate with appropriate investigative modalities, correlate, and then execute your plan. This is exactly what we need to do. Let's look at few of the situations. Here it's a clear cut. You will say it's a very simple case. Come on. All you need to do is an anterior oblong. I agree with that. Okay. This is a very simple, straightforward hemangioma, which we operated. And day one, you get this is your post-operative result. Now let's look at the next scenario where you have a situation. It's not moving. Sabotage. Yeah, so it's moving. So this is in your, can I call this a complex scenario? Would you call it complex? Semi-complex? Yeah, it's a big tumor sitting in the most important area. And you can, with a simple, scarless, conjunctival approach, get the tumor out. All right, so this is one scenario. Now let's look at the next one, where another tumor, which is almost right behind the globe, it's kind of complex, it's close to the optic nerve. You have to get the tumor out. We've got it through a simple conjunctival approach. Now let's look at the next scenario. Here you do a little bit of a skin approach where the tumor is situated. We're using all the investigative modalities and we're trying to find out where the lesion is, and we are locating the lesion and getting it out. All right. And I'm simultaneously showing you the post-op results also. It wasn't the picture that you showed, you know, where the globe was sitting in the maxillary sinus. Okay, so that comes out. In toto, we don't have to go dig in posteriorly and, okay. And that comes out quite easily. And it's in toto. It's not being disrupted, it's not mutilated, it's not massacred. Okay. Now, the optic nerve sheath fenestration, which you all tend to do with your navigation unit. When approached appropriately, you can always get the fluid out. Then let's go to the next, I'm sorry, the previous procedure where a very large tumor like this, again, is approached with a simple, you know, you can just do a lateral canthotomy and cantholysis and then just do a little bit of a lateral incision and you get the big tumor out, right? So in all these cases, would you be using a navigation unit, Dr. Ganga?
Not for tumors.
Okay, right, okay. Okay, only, okay. So what are we dealing with most of the days in our day-to-day routine? All of us? Tumors, all right. I'm just making certain things sure for everybody. Okay, such large tumors without much of, and day one post-op, these are the results that you see. Now, he was talking about trauma. I had to show this picture, very recent picture. What do you see? It's not a pencil, it's a compass. You know, two children were fighting and the edge of the compass, I mentioned to you, Akshay, was stuck into the frontal bone, and this we got it removed without the navigation unit. Now my questions to you. You might wonder, see, it's like the grapes are sour when you don't reach it. No, I did try navigation unit. I did. But I used to do 3 or 4 orbitotomies in the morning session. With the navigation unit, I was trying to struggle and finish one case in one session. So it's very difficult, time consuming. Okay, so I did try. It's not that I did not try and I'm talking about it. Now, the questions for you. Why choose a difficult option when you have an easier route? Who will pay for this? I'm asking from the Indian context. Singapore is very different. What about the theater time, the surgeon time, and the learning curve? Why GPS to reach your home, Ganga? You have only one home, right? It'll be possible when zebras are on my street. Thank you very much.
That was extremely aggressive, and I'm almost feeling sorry for you, Ganga. But yeah,
Keep the questions. Keep the questions.
yeah. So
Okay.
so
Back to me. Was this a debate or was this a personal question and answer session? Let's have the. So I'm not saying navigation is a no. I'm not saying that at all. In our context, today's scenario, what we are practicing, we have a unit. We have a navigation unit, but we cannot afford to practice it on every patient. And we cannot afford the time. With the volume and the pathology that we have, I'm being very honest. So I'm not saying it's going to come probably in future. Probably that's the future. But today's scenario, we're talking about today's. In Cochin, in this boat, I think what I practice, I'm honestly.
yeah, and well said and point taken. And I just think that there is a role, especially in trauma cases, in bad trauma, because it's really hard to figure out what's there in the complex mid-facial traumas that even we in a hospital, we get a lot of those. So we don't have a navigation unit. But I think we can't say that there is absolutely no role. There definitely is some role. Yeah. So
Why GPS when you're going home? If you're driving from Chennai to Madurai to your place and your major highway is blocked, you don't know the neighborhood. You don't know all the other routes you have to take, which is open to reach your home. Keep driving rather than wait for the highway to open up. That's why you need navigation to reach home.
Ganga has always some extreme thoughts.
okay.
I don't
All right, we're going to
understand.
end this.
Why can't you-
We have one more debate. You guys can go upstairs and fight it out. And I'll even keep the bouncers downstairs, Jao. Okay. So we have, I think only Mahesh is left, huh? Yeah. Dr. Mahesh. Okay, so Dr. Mahesh. Yeah, Rituja, you abandoned. You were supposed to be timing and helping us. But then you time also, na? So we are talking on juvenile melanoma.
Yeah, my opponents kept changing. So it was Santosh Unawar, then it was Fairuz. I don't know. Now it is Parag, poor fellow. Okay, the debate was supposed to be uveal melanoma. Is it plaque brachytherapy or is it enucleation? So let's look at the classification. Let's look at the classification once again. So uveal melanoma, we can call it as small melanoma, which is less than 2.5 millimeters in height, and 2.5 to 10 is medium, and large is more than 10 millimeters in height. And the NCCN is, when it uses, instead of 16, it uses 18 millimeters in height. So the collaborative ocular melanoma study showed that the plaque brachytherapy is the treatment for medium-sized choroidal melanoma. It tends to save the eye and possibly some vision. So this is a ruthenium plaque which we stick onto the sclera. So this is a post-treatment. So you can see the melanoma is regressed post-treatment. So what is the main advantage of brachytherapy? You got to keep the eye and some vision. In contrast to an enucleation where you don't have the eye, obviously no vision. The survival. So are we compromising on the survival if in case we do brachytherapy versus enucleation? So if you do enucleation, the tumor is out of the body and it's not unlikely to spread. But the collaborative ocular melanoma study once again showed that there is a 12-year follow-up as well. The survival is the same. Whether you enucleate the eye or do brachytherapy, the survival at 5 years is 81% and at 12 years is 57%. It's the same. But in contrast, in brachytherapy, you get to keep the eye. So this is for medium-sized melanoma. What about large melanomas? The COM study said that for large melanomas, enucleate. But this is a recent study, which is a retrospective study published in 2020 of 7,096 patients. It includes everything, small, medium, and large melanomas. So they compared brachytherapy versus enucleation in this large series of patients. And what do you see? That brachytherapy patients did better overall. In the small melanoma, medium melanoma, and large melanoma, the brachytherapy patients did very well. As you can see, all were statistically significant results. And large melanomas, around 67.3% per percent survived, as in contrast to 45.7% who underwent enucleation. So even in large melanomas, which were traditionally enucleated, you can do brachytherapy, and the survival is even better in contrast to enucleation. So in melanoma, the tumor genetics plays a big role. So if the tumor is class 1A, only 2% have a metastatic risk. If it is class 1B, the 1A, 1B, and the 2A are based on the genetic makeup of the tumor. If it's 1B, 21% develop metastasis, in contrast to if it is class 2, 62% develop metastasis. So it depends on if they have a monosomy 3 or chromosome 8 deletion. And usually large melanomas are aggressive melanomas. And so the current concept is when you diagnose the patient to have a melanoma, a large melanoma, they are likely to have a micrometastasis. And no test will pick it up. But 5 years, 10 years down the line, they will have a metastasis. So having a large melanoma is a risk factor for increased risk of metastasis. And local therapy absolutely has no impact on survival. So you have a large melanoma which you want to enucleate, and this patient is going to die in the next 5 years. In contrast, you have a large melanoma, do brachytherapy. In the next 5 years, at least let him keep his eye. And subsequently, there are newer treatment options. Like instead of doing a single plaque, you do a staged plaque. You put once, and then about 3 to 4 months later, you put the plaque again. So very large melanomas, you can do a staged plaque as well. There are a couple of papers on doing a staged plaque as well for melanomas. So this is a picture I borrowed from one of the articles where they have done a staged plaque therapy. This is one case report where you can see the tumor has regressed. The second one where once again, after the staged plaque, the large melanoma has regressed. Yes, brachytherapy gives rise to vision loss. That's because of the radiation retinopathy and papillopathy. But then we have the Ganga gel where we use for every treatment, everything in the retina, you inject. So you inject the anti-VEGF agent. And in patients with toxic tumor syndrome, like what you can see on the right side, I am resecting the melanoma post-brachytherapy. So you reflect the retina and remove the tumor and put the retina back. And that decreases the risk of a recurrence of the radiation papillopathy. So brachytherapy allows us to have some vision preservation, may not be normal vision, better cost misses, survival same as enucleation. In contrast, enucleation, yes, you can see the enucleated socket, which moves very, very well by itself. This is one of my earlier enucleations. But you wait until you zoom back. So you can see that there is a gross difference. So if it's your own eye, which is not enucleated, it moves at least symmetrically. But however well you do an enucleation with an implant, it may move. But when you look at it bilaterally, with both eyes open, doesn't look too good. And of course, once you enucleate, there should be a care of the prosthesis and care of the socket as well. So why not when you can have the cake and eat it too? So prefer brachytherapy over enucleation. Thank you.
Thank you, Dr. Mahesh. We are short of time, so we're going to ask Dr. Parag to please come give his talk on enucleation. And please, it's very hard to be last, but you have to be brief.
Yeah, very brief. Yeah. So I'm a retina surgeon, and I thought the retina meetings were fun, but I'm really enjoying this meeting. So yeah, thank you. So Fairuz told me that you have to be funny, doing some funny slides. She told me at 11 a.m. this morning. So I thought the closest thing I'll just go buy a lungi and come, and that'll be the funniest thing. But then when they said that I'm speaking against Dr. Mahesh Shanmugam, how funny can that be? It's like a kindergarten student against the principal on how to run the school, the debate. So having said that, so enucleation for melanomas, like he rightly said, that it all depends on the size of the tumor. So we're not talking about small melanomas. They can be easily be tackled by TTT and other conservative methods of PDT. We're talking about the medium and the large size. So although they are quite common in the Caucasians, it's quite rare in the Indian scenario. And the Indian scenario, when we see the patient usually comes with a loss of vision and it will be a large mass. So where there is no point of doing a brachytherapy is a large melanoma, and mainly uh, the availability. Now he's talking about iodine 125 and the ruthenium plaques. They are not available easily everywhere, and only few centers have it. And there's a waiting time also. Like we do iodine brachytherapy. It's not like tomorrow we can do iodine brachytherapy. We have to wait for a month or at least 6 weeks. Now, when we talk about these trials of COMS and the brachytherapy they've done the same survival, I mean, I would not want me to be with a large tumor in my eye and wait for a 1.5 month and saying that the survival after 5 years is the same. I would long to get rid of it because we know the visual outcome is equally bad. When you talk about medium-sized tumors which are close to the macula, you're talking about a radiation dose of 85 gray. The tolerance dose of the macula and the optic nerve is only 55 gray. So anyway, the vision is not going to be there. And frankly, our patients, these are coming elderly patients, elderly, they are not that aesthetically that much at the Caucasian that we want to, cosmetically good. We just want to be okay, and we know that they'll be able to see, they'll be able to live a good life. So I still feel that enucleation has a bigger role than brachytherapy, and it's only for a selected few patients. Thank you.
Thanks. I think affordability is really a very big thing. Not too many people can afford. There aren't as many centers doing it. But yes. Okay, all patients going to Dr. Shanmugam. Yeah. Okay, so now thanks everybody. I think that was a really entertaining session, and I hope people have also learned something. Now,
Thank you all for being very participating and being very attentive in this debates. And it's been a very interesting session. I thank my chairperson, Dr. Anita, Dr. Marian Pauly for moderating, and all the listeners. And thank you all.
I mean, this is the most important part is to go up. It's very, very nice to enjoy the scenery of the state.